Right, good afternoon, everyone. Just to clarify, I'm not a doctor, but a pharmacist, and I was asked to give you a presentation this afternoon on the advances in antiplatelet therapy. So, it's quite clear that platelets play a pivotal role in the pathophysiology of atherothrombosis during the acute coronary syndromes, and also in the development of ischemic complications following PCI, hence the need for antiplatelet therapy. So what I'm hoping to do during this presentation is give you a quick overview of what our current treatment options are, discuss the limitations associated with its use, and also review some strategies to overcome those limitations, either by way of alternative treatment prescribing options or through the use of alternative agents. So, since the late 90s, dual antiplatelet therapy with aspirin and clopidogrel has been the mainstay of treatment for patients presenting with ACS. And clopidogrel, until recently, was universally accepted as the thienopyridine of choice, with evidence of benefits across the whole spectrum of ACS. A large number of clinical trials have demonstrated that the addition of clopidogrel to standard aspirin treatment can lead to marked reductions in major adverse cardiac events and stent thrombosis. However, despite the use of dual antiplatelet therapy, 20% of patients still present with recurrent ischemic complications. And this has been attributed to antiplatelet treatment failure due to limitations with clopidogrel itself. So just a quick summary. Clopidogrel is a thienopyridine. In terms of its limitations, the key factor is it's very slow in onset. So despite the administration of a 600 milligram loading dose, it still takes approximately 2 to 4 hours for you to see effective inhibition of platelet activity. And even then, it's quite modest in that we may see 40% of platelet inactivity, which in the context of primary PCI or urgent PCI is quite a disadvantage because we often need optimal levels of platelet inhibition almost immediately. The other limitation to clopidogrel is that it's an irreversible inhibitor of the P2Y12 receptor. So in order to reverse or overcome the effects of clopidogrel, we're very much reliant on regeneration of platelets. And again, this is potentially problematic for patients who may present with uncontrolled bleeding or for those who undergo urgent bypass graft surgery because there are increased risk of hemorrhagic complications. And the last point, which is probably the most important, is that clopidogrel is a prodrug, and it's very much dependent on conversion via the 2C19 allele to its active form. And there's considerable heterogeneity in the general population amongst the activity of the cytochrome P450 enzyme, in that up to 30% of patients may have impairments in the C19 allele or polymorphisms, which lead to impaired conversion of the prodrug into the active form. So in terms of alternative treatment strategies that we could employ to overcome these limitations, the first is using a double dose of clopidogrel. So we double the loading dose and double the maintenance dose. And this was investigated as part of the current OASIS 7 trial. And the hypothesis here was that if we double the loading and maintenance doses, we achieve faster onset of action and slightly greater inhibition of platelet activity. And to a certain extent, this was achieved in that we saw a significant reduction of 42% in the incidence of stent thrombosis, but in actual fact, the primary endpoint of cardiovascular death, MI, and stroke was not significantly different in the patient group who did not undergo PCI, but we did see a reduction in those who were stented. However, even though we doubled the dose of clopidogrel, we're not actually dealing with or overcoming the limitations that are present with the drug. So it doesn't overcome the fact that you have interpatient variability, and it doesn't compensate for the fact that there may be some patients who are non-responders or demonstrate clopidogrel resistance. So in view of this, we have some alternative antiplatelet agents, the first of which is prasugrel, which again is an irreversible antagonist of the P2Y12 receptor. Like clopidogrel, it's an oral drug and it's a prodrug. However, prasugrel's unique structure allows for more faster and complete inhibition from the gut, with more rapid and potent onset of inhibition of platelet activity, which directly translates into improved clinical outcomes. And we can see here that following absorption from the gut, we have a partially active compound, which then is reliant on the cytochrome P450 pathway for conversion to the active molecule, in comparison to clopidogrel, where it's very much dependent on a two-step conversion process. So these two figures again demonstrate the superiority of prasugrel over clopidogrel in that we have more rapid and complete onset of inhibition of platelet activity. So within half an hour of administration, you see almost 30% inhibition of platelet activity compared to 5% for clopidogrel. And after 2 hours, you're looking at 70% compared to 20% for clopidogrel. So in the context of primary PCI, this is actually quite an advantage. However, more interestingly is this second figure here, which demonstrates that prasugrel is not limited by genetic polymorphism, as is the case with clopidogrel. We can see that for clopidogrel, there's wide interpatient variability, in that even after the administration of the drug, there's a significant proportion of patients who don't respond. So you can administer clopidogrel and they display absolutely no antiplatelet effect whatsoever. And this proportion of patients are exposed to increased risk of ischemic complications. However, with prasugrel, we have a baseline inhibition of platelet activity at 50%, with much less interpatient variability. So they're the two strengths associated with the use of prasugrel in clinical practice. The key study to support the use of prasugrel is the Triton-TIMI 38 study, in which patients presenting with ACS who were to undergo PCI were randomized to either clopidogrel or prasugrel. In terms of the primary endpoints, we saw a significant reduction of 18% in terms of the primary composite endpoints. And in terms of stent thrombosis, again, both early and late stent thrombosis were reduced by more than 50% in the prasugrel-treated groups. So again, validating the hypothesis that more rapid and complete inhibition of platelet activity leads to a reduction in ischemic complications and stent thrombosis. However, this is at the expense of increased in bleeding complications. And interestingly, both the rates of cabbage-related and non-cabbage-related bleeding were significantly increased in the prasugrel-treated group. These graphs just highlight those patient groups in whom prasugrel treatment led to greater benefits. So those patients presenting following a STEMI and undergoing primary PCI, prasugrel led to a 32% reduction in the primary composite endpoint. And interestingly, for diabetic patients, who we know up to 40% of diabetic patients are resistant to clopidogrel, we saw a 28% relative risk reduction in the instance of the primary endpoints. A series of post-hoc subgroup analyses were also undertaken following the Triton-TIMI 38 study. And these identify 3 patient groups in which prasugrel had less net clinical benefit and absolute greater bleeding risk. And they were patients over the age of 75, under 60 kilos, and those with a history of previous TIA or stroke. So in view of the outcomes of the Triton-TIMI study, NICE issued some recommendations in 2009 outlining those patient groups in whom prasugrel treatment would be appropriate and those in whom it should be avoided. So indications for use would include primary PCI, those patients who are diabetic and will be undergoing stenting, and those patients who present with stent thrombosis despite treatment with clopidogrel. And the only absolute contraindication to the use of prasugrel is a history of previous stroke or TIA. So you can see we have some very specific and restrictive indications for use. In contrast to clopidogrel, it's no longer a one-size-fits-all strategy in terms of prescribing antiplatelet therapy. So Triton was very good at establishing the place in therapy in terms of early intervention. However, one area where we were lacking in terms of data was for those patients with unstable angina or NSTEMI who were to be managed without revascularization, so those would be managed medically. And this was addressed during the Trilogy ACS study, and unfortunately the outcomes of the Trilogy study demonstrate that there was no significant difference in terms of outcomes for those patients who were treated with prasugrel. So again, reinforcing the message that prasugrel really is a drug or drug for patients undergoing early intervention. Now, the most recent addition to the antiplatelet family is ticagrelor, which is a novel class of agents. Unlike clopidogrel and prasugrel, it isn't a thienopyridine, nor is it a prodrug, but it's a directly active compound that doesn't require metabolic activation and therefore isn't subjected to genetic polymorphisms. And the most attractive feature about ticagrelor is its reversibility, which I'll come on to in a moment. The key study supporting the use of ticagrelor was the Plato study, in which over 18,000 patients presenting with ACS, who were either going to be managed with intervention or managed medically, were randomized to receive treatment with either ticagrelor or clopidogrel. And we can see that in the clopidogrel-treated group, there was 11.7% incidence of the primary endpoints, and it only occurred in 9.8% of patients treated with ticagrelor. And this translates into ticagrelor being associated with a 16% relative risk reduction in the primary composite endpoint. And interestingly, there was also a 22% reduction in all-cause mortality. And in fact, the findings of Plato indicate that ticagrelor is the first antiplatelet agent since aspirin to demonstrate a mortality reduction for the treatment of acute myocardial infarction. As well as the mortality benefits, there was also a significant reduction in the incidence of stent thrombosis. And in contrast to the Triton-TIMI study, these benefits were achieved without an increase in cabbage-related bleeding. However, there was a slight increase in non-cabbage-related bleeding, particularly intracranial bleeds. In terms of other off-target effects associated with ticagrelor, a significant feature of the study was dyspnea, or shortness of breath. 13.8% of patients who were treated with ticagrelor did experience shortness of breath, but this was shown to be unrelated to changes in pulmonary or cardiac function. Another interesting side effect was an increase in the incidence of asymptomatic ventricular pauses. However, this didn't warrant any further intervention in terms of an increase in pacemaker insertion. So, following the favourable outcomes of the Plato study, NICE issued some guidance in 2011 where they recommend its use across the board. So there are no restrictions as to which patient groups may benefit from treatment because of the mortality benefit we saw across all patient groups in the Plato study. Now, what is of interest is the reversibility of ticagrelor. We've already established that it's more potent in onset because you see greater inhibition of platelet activity. But its reversal, or the offset, is also more rapid in comparison to clopidogrel. So we can see that, within 24 hours of the dose being stopped, we see a 50% reduction in inhibition of platelet activity. And this is why we need to have twice-daily dosing with ticagrelor. The other advantage is 72 hours after stopping ticagrelor, the levels of platelet inhibition are actually less than that seen with clopidogrel at day 5. And this could account for why, in the study, there was no difference in terms of cabbage-related bleeding. Now, I hadn't come across any similar data for prasugrel until I did a quick search. And this is some data from the recovery study, which was undertaken in 2012, to try and demonstrate what the dynamics of platelet function were after prasugrel discontinuation. And we can see here that the offset for prasugrel is far longer than that for clopidogrel. So after 5 to 6 days of discontinuation with clopidogrel, we see a return to almost normal baseline platelet function. However, with prasugrel, it's far longer. And this could account for why there was such a significant increase in cabbage-related and non-cabbage-related bleeding in the Triton-TIMI 38 study. Now, there are no head-to-head trials that compare the two agents, and I acknowledge that the two studies were very different in design. But based on what we've just discussed, there are some conclusions that we can draw. Both agents are superior to clopidogrel, in that we see more rapid onset of action with greater and more consistent levels of platelet inhibition, which directly translates into reduction in ischemic complications and reduction in stent thrombosis. Both agents are associated with an increase in bleeding. However, ticagrelor didn't demonstrate an increase in cabbage-related bleeding. And what we should bear in mind is, from a pharmacy perspective, both agents are considerably more expensive than generic clopidogrel. So while antiplatelet therapy, or developments in antiplatelet therapy, were very much centered on trying to address the limitations associated with clopidogrel, as our understanding of platelet biology and the mechanisms by which platelets become activated has increased, it's become apparent that there are a whole host of complex signaling pathways involved in platelet activation. And in terms of future therapies and things that we may want to look out for, interesting agents are the PAR1 receptor antagonists, for example, vorapaxar and atopaxar. These were thought to show considerable promise because they reduce the incidence of thrombosis without apparently increasing the risk of bleeding, since they don't affect the pathway involved in hemostasis. However, the two big studies supporting vorapaxar, TRACER and TRAP2, indicated quite a large safety signal in terms of an increase in intracranial hemorrhaging or intracranial bleeds following the use of these agents. In terms of new P2Y12 inhibitors that we may want to keep an eye out for, cangrelor and elinagrel are two reversible P2Y12 inhibitors. And in terms of the ideal characteristics of what we'd want with an antiplatelet agent, it being rapid in onset and rapid in offset, being available as an oral and an intravenous agent, elinagrel may actually be the drug to fit all of those requirements. So, despite the use of dual antiplatelet therapy with aspirin and clopidogrel, a significant proportion of patients still experience ischemic complications, and this is often due to limitations with clopidogrel itself. New platelet inhibitors have continued to be an important avenue of investigation and have led to the development of agents such as ticagrelor and prasugrel, both of which have an improved pharmacokinetic and pharmacodynamic profile compared to clopidogrel. And I guess the holy grail in terms of antiplatelet therapy is to try and discover a drug that's effective at preventing thrombosis without necessarily increasing the risk of bleeding as well. So, thank you. That's quite a quick overview of the advances.